Is that on?
No.
On? On?
No.
On? On?
Yes.
On. Good. Well, look, it's a real challenge to follow a living national treasure. Frankly, I would like to have just sat back and listened to that because that discussion could go all sorts of places. And it's interesting that you've raised the issue of violence. Last week I was in Adelaide and I was talking to a public gathering about Indigenous violence, and I was doing that because at the moment there are certain ways in which Indigenous violence is being constructed in the press and in other places, which I think are highly problematic, and raise and challenge the issue of tradition and being in remote Australia as being fundamental risk factors of violence, which will be addressed by either reducing people's traditional practices or just shifting out of remote Australia. And this is really problematic. It's a political construction of that issue, which perhaps we'll come to at the end, because the third P we're going to talk about tonight is the P of politics. Before I proceed, I should acknowledge the traditional owners of this land, and also acknowledge that in this audience there are going to be people who've been affected by suicide. A number of years ago I was in Normanton doing a series of consultations around setting up services, mental health services. And as we started talking, an Aboriginal woman got up in the audience and began to tell me about a relative of hers who committed suicide. Now, we weren't there to talk about suicide, but in the next 20 minutes, 6 women got up and told their story of having lost somebody. So I take it as a given, and I know it's the case, that people in this audience have been affected by suicide. And I'd simply like to say this, that it is okay to shed a tear, and it's also okay to leave, that we need to talk about these issues. So just to come back to the issue of violence, though, because the statistics on suicide look very like the statistics of the actions in violence. Because deaths from homicide are largely, although the deaths from homicide are male and female, the perpetrators are male. And the perpetrators of suicide are male as well. We've already heard from Miriam, and the statistics that we've heard from Daily River are pretty much what we'd expect if we look nationally. That suicide tends to cluster amongst young adult people. They tend to be male. The ratio is probably something like 4 or 5 to 1. And it seems to me that sometimes there's almost a coincidental difference in terms of coincidence in terms of whether violence is acted against someone else or against the self. Now, I'm a clinician, and so I'm not a researcher, but I deal with these issues pretty frequently in my clinical practice. And I remember about 20, 25 years ago meeting a guy in the Kimberley who had disemboweled himself. And he'd been brought down from Wyndham to Derby Hospital, and I went to see him. And the story was this, that he'd been in Wyndham drinking very heavily. He was from Ombulgurri, Forest River, and he'd come into town, he was drinking heavily, his partner was drinking, there was a lot of jealousing going on, and at one point he picked up this flagon, he smashed it on the ground, and he stood up to plunge it into his partner's face. And before he did that, he stopped, he turned around, and he plunged it into his abdomen. And at that moment, I think it could have gone either way. And importantly, the 2 objects of his rage are the 2 most important objects in his life. The 2 most important relational objects, himself and his loved one. And I think we need to ask, why is there this kind of confusion and rage, particularly for men, at those important relational objects? Before I talk about the first P, I'd like to tell a bit of a story, and it relates to, I'm not from the Northern Territory and I'm not Aboriginal, And I'd like to tell a story about a place in Queensland that experienced enormous tragedies from suicide, and that's the community of Yarrabah. Lots of people will know that in the 1980s there was a tragic space of suicide and some 17, 18 young people died. When that process was ongoing, the people at Yarrabah didn't stop still and wait for it to subside. They did a lot of things. They went and got the mental health team from Queensland Health to come out regularly. They never used to visit before, so they started coming. The suicides continued. They then heard that there were programs in Canada relating to Indigenous First Nation suicide that were effective, so they sent a team over there. They then got Native American people to come out to Yarrabah. The suicides continued. They got a particular university to get involved and do some work to stop this process. And then they hired a firm, a private company in Sydney, to come up whose specific area of expertise was suicide, and the suicides continued. And then around 1995, 1996, something important happened. It was almost like a penny dropped, and a public meeting was held in the basketball court at Yarrabah. And I was fortunate enough to be able to attend. I was in the background there. And before the meeting started, the chairperson at the time got up, the minister, and he said, "We're going to have a minute's silence for all those people who've died." So immediately there was silence. But suddenly there was this scream. At the back there was a wail at the back of the auditorium, and it was a woman whose wailing really kind of captured the sorrow of the community as a whole. And I didn't turn around. And then after that, people got on with the business. And from that, I think, in a sense, what happened is people owned that problem and started to define their own solutions. So fast forward about 10 years, and I'm running a conference in Yarrabah, and predictably something's gone wrong with catering. And at lunchtime, I'm out there, running on, wiping on the Miracle Whipped baked sandwiches. And I'm talking to a lady, and I tell this story. I said, I remember, because we just released a suicide prevention resource. And I said to her, I remember that day 10 years ago when that happened, and there was a woman who wailed at that time. And she said, "Ernest, that was me." And I said, "Samelia, I'm really surprised. I never knew it was you." And then she floored me, because she turned around and said to me, "Look, we were very grateful for what you said." And I was scratching my head because I didn't know what I said. I couldn't remember it at all. So I had to admit it. And I said, "Samelia, I'm afraid I don't know what I said." She said, "You didn't tell us what to do." And I think there's an important message here, because we as professionals, I think, feel that we're required to rock up with a solution. And I think that in confronting an issue as complex as this, we need to be a lot more humble. So let me talk about the 3 Ps and tell a little bit of a story from my perspective about change. The first P is people. Now, we know that people that are vulnerable at this point in time in 2013, they tend to be young adult males, and these events occur often and impulsively at a time of heightened emotional tension. But this was not always the case. In fact, if we go back 40 years ago, suicide was extremely uncommon in Aboriginal Australia. And when it began to occur in Aboriginal Australia, it wasn't young men who were the main group affected. In fact, the first sets of suicides that occurred were older men in their 30s and 40s. Old, unfortunately, taking into account Aboriginal lifespans. That changed dramatically in the late 1980s, and it changed around the time of the Royal Commission into Aboriginal Deaths in Custody. And then we saw a sudden upsurge in deaths of adolescents and young adults. And those tended to move from being initially focused around towns into remote settings. So there was a process of generalising. But that increase in deaths had been preceded. Before that, I'd been in the Kimberley doing some research, and one of the things that I did looking at this increase in suicides that had occurred in the 1980s, was to ask the question, well, how had people died before that? So I looked at all of the deaths of Aboriginal people in the Kimberley for some 30 years, and there was an interesting pattern that emerged. And the pattern was this, that from the 1950s through to the early 70s, the deaths from non-natural causes, homicide, motor vehicle accidents and accidents, there were no suicides. In fact, there were 3, but virtually no suicides, were very low. It was 2 and 4% of female and male deaths, respectively, were from non-natural causes. From the beginning of the 1970s, it skyrocketed. It went up over the next 15 years to 15% of female and 25% of male deaths. It increased by a factor of 6. Well, what happened in the early 1970s? Well, alcohol became legal then, so it's tempting to say that it's alcohol, but you've got to contextualise it, because that was a time of profound social change. As Aboriginal people were being forced off stations for economic reasons, they were being brought into towns and enrolled into the economic system, which translated to unemployment. Jobs in the cattle industry had disappeared as the world financial crisis, the oil embargo, and an embargo on Australian lean beef kicked in, so there were no jobs. And these were men who accessed alcohol, largely men, but later women. As young adults, they were the first generation to hit it at the earliest age that they could legally drink. And what we saw was this upsurge in deaths from misadventure. It was really social turmoil and chaos. And now I mentioned that there were no suicides in that group, only a few. In fact, the suicides didn't start to occur in the Kimberley and elsewhere in Australia until the late 1980s, around the time of the Royal Commission. Now, there's about 15 years difference between this increase in suicides of young adults, adolescents and young adults in the 80s, and this increase in deaths from misadventure and chaos in the 1970s. This group from whom young people were dying are the children of that first group. So this group of young people who were starting to show self-harmful behaviour and die are the first generation to have been raised in that environment of social turmoil. Their grandparents had never experienced it, so this was a precedent. Now, the picture actually doesn't stop there, because if we go on further, another sad tragedy is that in the 2000s we've begun to see children commit suicide. And we've had, in Queensland, the numbers are problematic because they're small, but Aboriginal suicides are 5 times more likely among children than amongst non-Indigenous people. Small numbers. But we had an opportunity to look at a group of young people who died by suicide, children, around 2000. And the findings were interesting because we looked at a whole range of issues that were putative causes of the sort of disturbance that might lead to suicide. Substance use, parents being present, sexual abuse, etc. And we looked at all of those things. And they were scattered amongst these kids, but there were 2 things that stood out. The first is that of those 5 children, there was only 1 biological parent present. The second, and associated with that, none of those children were in the school system. Why is this important? Well, these are the 2 most important holding environments. That these were children who were disengaged from home, disengaged from school. And when I, as a clinician, am working and hear about kids who are at risk, one of the things that just rings a bell is when kids don't have anchors. The second factor that stood out with those children is they had all witnessed self-harmful behaviour. In fact, this group who are committing suicide and who are acting out self-harm in the early 2000s are the first generation to have been raised in environments in which those behaviours were common. And importantly, I think that exposure and that developmental experiences of exposure are really important. Whilst we were doing some work in Queensland, we had the opportunity to look back at that group of people who had been talking about suicide and acting out in harmful ways, self-harmful ways back in the 80s. So we were able to look back 15 years. And around that time, somebody who was an academic here at CDU, Joe Reeser, and his cousin Paul, had done a survey in Yarrabah. And they'd done a survey of people who'd been talking about suicide, threatening suicide, and they'd surveyed a group of their peers. And we asked the question, are those people alive or have they died? And what we found out was that more of those people were dead than you'd expect, but they didn't die of suicide. They died in motor vehicle accidents, they died in accidents. And I think this raises an important issue because I think we need to consider lifestyles of risk. We end up being particularly obsessed with very discrete types of risk, that here's an individual who's at risk of suicide and these are the things that you're going to do. Well, in reality, these are young people who are at risk of all sorts of misadventure. So I think we need to think about risk more broadly. So in terms of people, we need to ask, well, why have these changes occurred? And secondly, in thinking about people, I think we need to think about lifestyles of risk rather than risk of suicide specifically. The second P is place. And we know that suicide is not evenly distributed across the country, across Aboriginal Australia. And certainly in North Queensland, there are places where suicide has been very common and places where it's been quite uncommon. And indeed, a number of years ago, we looked at suicide in Queensland and looked at the Indigenous suicides amongst those who died and asked the question, well, where do they come from? And from North Queensland, there was a significantly greater than expected burden of deaths. And indeed, that burden of deaths was even greater from a set of communities that we call dogged communities. They're really ex-mission, ex-government settlement communities that were set up by the Queensland government away from areas of economic opportunity and have particular histories. Those places had much greater levels of suicide than other Aboriginal places. And I might also add that the levels amongst the Torres Strait are very low. So it's not just about remoteness. The second thing that emerged was that when we looked at those communities, it wasn't that there was a gradual increase in suicide across those vulnerable settings. Indeed, what we saw was a series of waves. We saw a wave of suicides in the community of Yarrabah in the 1980s, another wave that took off in Palm Island, which received a lot of attention and publicity, bad publicity, another wave that occurred on Mornington Island, and then a wave in Carrinyarra. Each of them lasted 2 or 3 years. They were, in a sense, kind of self-limiting. But it also raised for us the importance of thinking about risk in another way. That rather than simply thinking about what is it about an individual that we need to worry about, it suggested that we've got to think about communities at risk, and that at particular times and for particular issues, specific communities can be at risk. And when we have some suicides occurring in an area, we know that the risk for the population as a whole increases. So in terms of the P for place, I think we've got to ask the question, what is it about the history and circumstances of place that inform vulnerability now? We also have to ask, well, why is this place vulnerable now? And finally, I think we have to ask, well, who are the people we learn from? We have a tendency to take our lessons from those people who've been through the grinder. And in fact, our colleagues from North America have made the point that in Canada, what often happens is the Ottawa effect. That there's a problem with youth suicide, so we go to communities where there's lots of youth suicide, take the results back to Ottawa, make a CD, and send it to communities that have never had suicide. So, you know, one have to ask, well, what's the point there? Why aren't we learning from those communities where there's never been a suicide about the cultural resiliences, the cultural strengths, and the social strengths that support that? Now, what about the P for politics? And I'll in the service of having time to discuss, I'll finish quickly. I put a P for politics because the way we construct suicide is really important, because it informs the sorts of solutions that are going to be put out there. And if you go to the literature, you'll find that there's a cookbook of different causes of suicide. And you can cluster those in different ways. And we have people in the audience who've had far better experience in this and hopefully will contribute afterwards to distilling meanings. But even if you think about personal meaning, suicide represents lots of different things. I mean, there are 4 that stand out for me. I mean, when we talk about somebody who's killed themselves, usually we think about something that relates to despair, which may equate to depression or whatever. But we also know that suicide occurs as a very angry statement. It may be anger that's directed at the self, but it can also be anger that's directed at other people. I used to work in Micronesia, and years ago they had a terrible, in the 70s, terrible problems with youth suicide. And there was a particular word that was used there called amwan. And amwan was a process whereby an individual would expect some kind of post-mortem consequences for others as a result of their death. Do we find this in Aboriginal Australia? Absolutely. I hear patients talking about this. I'm going to kill myself and that'll happen. There'll be payback when such and such happens. And there is this kind of retributive motivator. And then there are instrumental uses of this language. Now, I was reading in the Weekend Australian last year, I think, about a thing called the Little Red Threat Book from Central Australia. Does anybody here know about the Little Red Threat Book? Yeah, maybe you can talk about it afterwards, because, or mention it. My understanding is that this was a little book that was put together to help parents deal with children who are threatening to kill themselves in order to obtain money or cigarettes or whatever. Now, whether there is likely an intent or not behind that statement, that those statements are in the public domain elevates the risk for the population as a whole. So for us to presume that these very different intents relate to the same kind of structures and forces, I think is problematic, and we need to think very carefully about the ways in which we develop our responses, and to be cautious about medicalising. Now, I think that Aboriginal people require access to a full range of quality and effective services, and they deserve that as a human right, including mental health services. Do I think that that's going to address a problem like Aboriginal suicide? No, I don't. When I went to Queensland, I was the only mental health practitioner of any kind between Cairns and Papua New Guinea. There are now about 100. Mental health situation much worse. Suicides much worse. Now, if we wanted to say, well, okay, so what does this tell us about the evidence base? Perhaps it should suggest that we should close up shop and go home. But that same logic is being used by certain politicians in my state to close down what I would argue are fundamental services that are important for developing what I would suggest are the levers of opportunity. In the last year, we have closed down public health nutrition. We have closed down health promotion. We've closed down screening programs for kids. Now, the Aboriginal voters just are not seeing this, but it's Indigenous people who are most potently affected. So I think that there is an unfair kind of, when people say, well, where's the evidence base for health promotion? I could turn around and say, well, where's the evidence base for clinical practice? So I think that we need to be very careful of the way in which things are politically constructed. The last point I'd say is that is a story. I've obviously suggested from the story of change over time that I think that developmental experience is critical. And I think my absolute belief is that's the most important preventive work we can do, is having healthy babies who are safe in nurturing environments. About 10-15 years ago, I was fortunate to be here in the Northern Territory with a guy called David Sasher. David Sasher is an Afro-American guy who was at that time the Surgeon General of the United States. He was one of the few docs who got to wear a uniform with braid. So he was an important guy. He was also a professor at Harvard, and he asked Michael Wooldridge to expose him to Indigenous health. And Wooldridge took him to Central Australia, and they went to communities with a backdrop that you'd be familiar with. There was petrol sniffing, there was all sorts of problems. And as they're walking through the community, Sasha turned around to Wooldridge and he says, "You don't have a health problem here." He says, "You've got an education problem here." Now, what he was saying, he wasn't saying what you've got to do is close down the clinics and invest in schools. He wasn't saying that. He was saying, look, you've got to get the health services right, but if you want fundamental change, you need to invest in the front end. And I believe that that's absolutely critical for our task, and I think the Miriam Rose Foundation also acknowledges that in prioritising children and education as fundamental building blocks in approaching suicide prevention.